Well, welcome back, everyone. I think it's been 10 minutes, and we are going to go ahead and get started with chronic care issues in the area of cardiology. It's the last segment of the day and of the entire course, and we appreciate you guys hanging out with us to this point. It's my distinct pleasure to introduce our next speaker, Dr. Barbara Wiggins. Dr. Wiggins is a clinical pharmacy specialist in cardiology at the Medical University of South Carolina. She is also an adjunct professor at the South Carolina College of Pharmacy. She received her Bachelor of Science in Pharmacy from St. Louis College of Pharmacy and went on to receive her Doctor of Pharmacy degree from Virginia Commonwealth University, the Medical College of Virginia in Richmond. Some of her accomplishments include the Junior Alumni of the Year Award from St. Louis College of Pharmacy, Rho Chi. She's won clinical research awards. She is board certified. She is a fellow. She has received diplomate status with the Accreditation Council for Clinical Lipidology. She is a clinical lipid specialist, and you guys are in great company, and we'll learn a lot from Dr. Barbara Wiggins.
Okay, can everyone hear me? All right, so welcome to the last session. I'm going to do everything I can to get you out of here on time, as I know some of you probably have planes to catch. As Dr. Fink said, we're going to focus really on the more chronic management of a lot of cardiovascular disease states. So there is going to be some overlap between what Dr. Fink's presented and what I'm going to present, but hopefully they'll kind of blend nicely and so to hopefully give you a better global understanding of and management of these particular disease states. So let's get started. I have no conflicts of interest to disclose, and what we're going to cover today are heart failure, AFib, hypertension, dyslipidemia, and due to time constraints, I'm not going to cover chronic stable angina. It's in your handout. It's fairly well described. Described, so I think I'm going to leave that to you to just review on your own, just so that we can get you all out of here on time. Now, one thing just to briefly mention is you may or may not be aware that there are new guidelines that we've been kind of teased about for several months that are coming with regard to the management of hypertension and dyslipidemia. We've been waiting on these guidelines for a long time, and they're due to be out at any time. That's what we've been told. But what I want you to keep in mind that should those guidelines come out after this review course, it is unlikely that they will appear on the exam. So for the purposes of studying for the review course for the exam, we'll need to focus on what we go over today in the course of the presentation. Okay, so with that, we're going to start with heart failure and chronic heart failure therapy. We're going to start each of these with a case, pose a question, go through the information, and then ultimately end with the case to try to tie everything together for you and make it a little bit more easier to understand. So this particular patient is a 48-year-old female. She has alcohol-induced cardiomyopathy with an ejection fraction of around 20%. She has New York Heart Association Class 3 symptoms, and her blood pressure and heart rate are listed there as well as her labs. Pertinent medications that she's on: lisinopril 20, furosemide 40 BID, carvedilol, spironolactone, and DIG. So the question that we're going to try to answer now that she's in our outpatient setting is, do we need to change anything with her medications? How do we optimize her care? So the question then is going to be, what do we do? So our choices are to increase the carvedilol, increase the lisinopril, increase spironolactone, or increase digoxin. So before we get into specific drugs, I just want to give you just a little bit of background, because there are two types of heart failure. We predominantly focus on systolic dysfunction. It's the most common. And these are defined as patients that have an ejection fraction of less than 40%. The heart has taken some sort of hit, it's damaged, the pump doesn't work very well, the walls of the ventricle don't contract, cardiac output is reduced, and these patients suffer from a lot of symptoms, such as pulmonary congestion, edema, shortness of breath. Most of the time, it's caused by some sort of cardiovascular event, such as a large heart attack or maybe smaller heart attacks over a period of years that ultimately have impacted the function of the heart. However, there's also a segment of patients that don't always have it as a result of ischemic disease. These patients may be alcoholics, as our patient has an induced cardiomyopathy, peripartum, Some chemotherapeutic agents also can cause it as well, and viruses. There are many viruses that have been implicated, and typically younger patients are the ones that you see that cause in. So converse to that is diastolic dysfunction. And I'm not going to focus a lot of time on this particular form of heart failure because it's not the most common, and the data for benefit of the drugs that we use are not as great as they are with the systolic piece. So keep in mind that the differentiating factor really is the ejection fraction. Patients with diastolic dysfunction have preserved ejection fractions, typically greater than 50% or even higher. It's not that the heart doesn't contract well. The heart actually contracts well, but the heart doesn't relax. The left ventricle is very thick. You have less area to fill, and so you reduce your cardiac function. The main cause of that is long-standing hypertension. The heart's had to pump against a high pressure over a period of time. The wall becomes very thickened, and so therefore your overall relaxation is impaired. So that's a different part, and we'll talk just a little bit about medication therapy at the very end of the heart failure section, but for the most part going forward, we're going to concentrate on systolic dysfunction. So the heart failure stages, you may see this. I would not spend and focus a lot of time on this table. Just be familiar with it. It's really more utilized as a prognostic tool to aid clinicians to identify patients early on that exhibit risk factors for the development of heart failure so that lifestyle modifications and drug therapy can be initiated early to help offset the progression of the disease. It kind of piggybacks onto the New York Heart Association functional class. This table I would be familiar with. You probably need to be able to know this so that if you're given a patient, you kind of know what their functional class is. And as we go through the course of this section, there are certain drugs that are indicated in patients who are of a specific functional class. And that will become important when you try to manage these patients should you have a board question about how to treat them and which drugs to add. The goals of therapy. Because the pump doesn't work, things start backing up. The body tries to compensate by vasoconstricting, increasing blood pressure, retaining sodium and water, and it all ends up impacting us in a negative way. So we have to manage it by blocking a lot of those compensatory mechanisms to help patients feel better. And we do that with drug therapy. That is going to target all of these. Ultimately, we want to make patients feel better, relieve their symptoms, and the ultimate goal of reducing mortality and delaying the progression of worsening heart failure. So the way we do that is with drugs. Diuretics is one of the staples for managing patients with systolic dysfunction. Now, as Dr. Finks already mentioned, we use these in the inpatient setting, predominantly in the IV form. In the outpatient setting, we use them in the oral form. We manage patients very similarly as we do in the inpatient. They're just more aggressive on the inpatient side. We use the loop diuretics. They're the most efficacious. And then if we need add-on therapy, we may add a thiazide, and we'll talk just a little bit more about that in a moment. Potassium-sparing diuretics, such as spironolactone, are typically not added so much for their diuretic response, but more so for their mortality benefit. Short-term and long-term goals of diuretics. One important thing to keep in mind, diuretics do not reduce mortality in heart failure. So if you're given a question with regard to a drug class that has no benefit in heart failure or in terms of mortality, diuretics is one of those drug classes. They help patients feel better, they relieve symptoms, so certainly that is huge with regard to patients' quality of life and how they can function, but the mortality benefit is absent. Some caveats to use. Dr. Finks mentioned this and getting patients to a euvolemic state. When they come from her inpatient service to the outpatient side, we want to know this patient's dry weight, and we want to be able to ensure that they're getting adequate diuresis with what the medications they're currently on. So we want to make sure they continue to lose weight or stabilize their weight and keep it constant without gaining additional weight rapidly over several days. The other thing to think about in the outpatient setting is if a patient should succumb to some sort of a GI illness such as vomiting, diarrhea, where they lose a lot of fluid, we want to be careful about continuing their orals, and patients need to be educated because you could actually make things much worse by causing them to go into renal failure. So they are very tenuous, and it's important that these patients weigh themselves very carefully and daily and log it out so that they can monitor their weight as it fluctuates on a daily basis to some degree. The other thing that has to be done is these patients have to be monitored with returns of electrolytes. Potassium is one of the most critical ones. Patients with heart failure succumb to ventricular arrhythmias and sudden cardiac death. Hypokalemia can certainly predispose patients to that, so we have to be cautious and they need to be monitored appropriately. Combination therapy may be needed. We've already alluded to this in the acute, and I've already alluded to this earlier as well. We start them on an oral loop diuretic. If we get up to a really high dose, we're going to be worried about potential adverse effects. So we are going to then ultimately maybe have to add a second agent to get sequential nephron blockade and adequate diuresis. But in general, we start at a low dose, monitor responsiveness, and then increase it as necessary. In terms of doses, what you have, you'll see the maximum doses listed here. Really, I wouldn't even go and put any value in that. We don't go that high. Again, because of the toxicities, we would add a second agent before we would get to that maximum dose. So if you get up to 160 or so of Lasix, maybe once a day, even sometimes twice a day, which is really higher than we tend to push it in the outpatient side, we would consider adding a metolazone. That would be maybe once a week or 3 times a week or something like that. There's a lot of variation in how these drugs are prescribed in the outpatient setting. You can add that on to maintain your diuresis. Now, in the setting of patients who have chronic renal insufficiency, metolazone is a better option than some of the other thiazides because it's more effective at reduced creatinine clearances, and that's important for you to know as well. All right, angiotensin receptor blockers, those are the next one, angiotensin converting enzyme inhibitors, are the next class that we utilize in heart failure. These drugs are typically started in the hospital when they are acutely initiated, and then we see them in the outpatient side and we try to titrate these drugs as much as we can in the outpatient setting. These drugs have a mortality benefit and it's substantial. These are generally the first drugs that are added to a heart failure regimen in addition to the diuretic therapy. They decrease hospitalizations and they improve patients' symptoms. Now, the compensatory responses that I talked about earlier, the ACE inhibitors kind of blunt some of those compensatory responses, so we get a reduced vasoconstriction, and we also impact the remodeling process as well. Now, the bold type here is what you need to know, that ACE inhibitors should be initiated in all patients with LV dysfunction. So it's a key med that all these patients should be on. Dosing is titrated very slowly. We start low and titrate it up every 1 to 4 weeks depending on patient tolerability. And so that has to do with how they're able to handle the blood pressure lowering of the drug in addition to the diuretics that they're on and how well they tolerate it overall. From a monitoring standpoint, if they have elevated serum creatinine, that could be potentially a problem. Potassium needs to be monitored because it also increases potassium. And we do anticipate or expect a 20 to 30% change in serum creatinine concentrations upon initiation, and we're willing to tolerate that. So just keep that in mind as well. Potassium should be monitored within 3 days after therapy initiation to see how patients will respond. The adverse effects associated with ACE inhibitors are cough and angioedema. Those are the ones we most commonly worry about. Cough, unfortunately, can occur at any time after therapy initiation. So it can occur early, it can occur late. So there's no cut point to say that it cannot be an ACE inhibitor. Now, should it become extremely bothersome, we could switch to the ARBs or angiotensin receptor blockers. I'm not going to go in depth with those agents today. They are an alternative to an ACE inhibitor in those patients unable to tolerate them, but the majority of the data is with ACE inhibitors, so those are your primary go-to agents. Angioedema is another serious adverse effect associated with ACE inhibitors, and ARBs are an option as an alternative. One of the important things about ACE inhibitors is that we want to get them to a target dose. The benefit with ACE inhibitors increases as you get them to a target dose of these agents. So if you can get them on a small dose initially, that's great, but we really want to continue to try to increase the dose to the target dose over time. Now, what's nice about the ACE inhibitors is it really doesn't matter which one you use. It's deemed the benefit is a class effect, so So you can pick whichever one that you like, and the patient can take that one. Although some may have better data or more data than others, we don't discriminate against the agents in this class. So you can use any of them that you want. Now, the beta blockers. Beta blockers also reduce mortality. They are added on to ACE inhibitors. They decrease hospitalizations and improve symptoms just as with the ACE inhibitors. Their mechanism of action is obviously to reduce catecholamine response. They also reduce ventricular arrhythmias, and as I've already mentioned, this is one of the issues with heart failure is ventricular arrhythmias and sudden cardiac death. And again, in bold type, should be administered to all patients with LV dysfunction. From a dosing standpoint, we start low, just as we do with ACE inhibitors, and we titrate up every couple of weeks to, again, target doses. Now, as with ACE inhibitors, as you increase the dose of beta blocker, you get an increase in benefit. However, the benefit is higher with the beta blockers as you get to target doses than it is with ACE inhibitors. So if you have to choose which one to titrate first, the beta blocker is where you want to go first. So if patients have difficulty with blood pressure, if you have them on an ACE and a beta blocker, you'd want to lower your ACE inhibitor dose first and then titrate your beta blocker up rather than the other way around, just because you want to get your beta blocker up to the target dose. In terms of the beta blockers and target doses, they're listed here for you. One difference with the beta blockers compared to ACE inhibitors is that we only recommend 3 particular beta blockers in heart failure management. And that has to do with the inconsistency in data with other beta blockers that are currently available. So we recommend bisoprolol, carvedilol, and metoprolol succinate, not the short-acting. Unfortunately, in terms of cost, carvedilol is the least expensive, so that would be your go-to if cost was an issue, because the metoprolol succinate is still relatively expensive depending on where you are. Now, the other option, if hypotension is a problem and it inhibits you from being able to titrate your medications, if the patient's, say, on carvedilol, you could switch to metoprolol, take away that alpha blockade, maybe give yourself a little bit more blood pressure, and allow you to titrate your doses up as well. But keep in mind, these are the only 3 that are indicated for heart failure. So if you have a test question that has anything other than these 3 listed, you'll know which one is not correct. And then we have aldosterone antagonists. Spironolactone has been studied in class 3 and class 4 heart failure. It also decreases mortality when added to standard heart failure therapy, such as beta blockers and ACE inhibitors. This is not a drug that would be added first. It's added after the other 2 are already on board. It also decreases hospitalizations as well as improvement in symptoms. Eplerenone is another one that has been studied in class 2. So it also has shown benefit in class 2 heart failure patients. And as Dr. Finks mentioned, eplerenone has also shown benefit in patients post-MI who develop LV dysfunction or who are diabetic. Now, with regard to recommendations, however, the current recommendation is that aldosterone antagonists be given in patients with class 3 and class 4 heart failure and in patients post-MI. So that's where that drug falls into place. So we wouldn't put it in all of our heart failure patients, and in fact that was one of the problems that happened once the big study called the ROUSE study was published with spironolactone, that it showed such great benefit, a 30% additional reduction in mortality in heart failure patients, was that every patient got put on it. And unfortunately the ERs saw a lot of additional cases of hyperkalemia as a result, because of the lack of monitoring and not watching renal function when the drug was initiated. So there are certain caveats, obviously, to starting this drug. ACE inhibitors retain potassium. Spironolactone causes potassium to go up as well. So you have a double whammy. So you really have to be careful about potassium, serum potassium concentrations in these patients. So renal insufficiency certainly is always a caution when initiating spironolactone. If their potassium continues to climb, you may have to reduce the dose or discontinue therapy. Serum creatinines greater than 2.5 certainly are cautionary of whether or not you should even use it at all. So just keep that in mind as well. And then we have digoxin as a choice to add on. This would, again, be something that we would do sort of after everything else. So if patients continue to have symptoms after ACE and beta blocker therapy, as well as maybe spironolactone, if they can tolerate it or take it, then digoxin is certainly an option. But we would want to optimize our other therapies first, and if patients are still symptomatic, digoxin could then be considered. The dosing of digoxin obviously is going to depend on patients' renal function. Generally, we start at 125 a day, and for most patients, they can tolerate that. However, if they have impaired renal function, it's going to be even more difficult. Sometimes we dose it 3 times a week or every other day, and that comes into a concern, obviously, for compliance and patients remembering and not inappropriately taking it too often. So you really have to have the right patient in order to tailor it to that level. It is renally eliminated. We don't try to push the levels. In general, we don't typically monitor levels for digoxin unless we suspect that they may be toxic. The biggest drug interaction that you'll probably encounter in a cardiovascular patient is with amiodarone. Amiodarone can increase digoxin levels by about 70%. So you do have to make an adjustment in digoxin if you add amiodarone on board, which we'll talk about that drug in particular a little bit later when we talk about AFib. So in terms of the drugs for heart failure, diuretics, beta blockers, ACE inhibitors, aldosterone antagonists, and digoxin for reduction in hospitalizations. Digoxin has no mortality benefit in heart failure. You have 3 that do, and that's your beta blockers, ACE, and spironolactone or aldosterone antagonists. So ideally, you want to get them on all those medications. Not all patients are going to tolerate them, but you want to optimize your doses out the best you can to give the patient the best benefit that they can be gained from these agents. So if we were to go back to our patient, our 48-year-old female with alcohol-induced cardiomyopathy, what do you think the best approach would be to maximize her heart failure? Right, exactly. You could say that she's already hit her target dose of ACE inhibitor, although some references will tell you 40 milligrams is a target dose. But we want to get her beta blocker up. And so carvedilol, increasing the carvedilol is the right way to go with this particular case. Now there is another drug combination that may be added in African Americans, and that is the hydralazine isosorbide combination. This is a combination that's added to everything else. So it's a lot of medications, it's a huge pill burden, so one needs to really optimize the other agents first before considering adding this. The AHEF trial is what kind of brought this drug combination into play for the African American population, decreased mortality and decreased hospitalizations. You get kind of a balanced preload and afterload reduction with the combination, but again, the issue is really going to be the pill burden, and being able to take something 3 times a day. Compliance also is going to be driven by that as well. So conceivably, a patient with heart failure could be on 7 medications. If they were optimized on everything, they could be optimized with what the studies show, 7 meds. And that's just for one disease state. So keep that in mind as well. Now, on the converse, when we look at patients with heart failure and we see them in the outpatient setting, one of the things we always need to do is do a med reconciliation on everybody. And one important thing to think about is the medications that may be harmful in heart failure and those agents that patients should avoid taking. So I've highlighted a few of those here for you. So for example, those that cause fluid retention, non-steroidal anti-inflammatory agents, corticosteroids, thiazolidine-diones, those agents all can cause fluid retention and worsen symptoms, so those should be avoided. Those with negative inotropic effects, such as calcium channel blockers, should be avoided, and those that can increase ventricular arrhythmias, such as cilostazol. I see cilostazol prescribed quite a bit for peripheral vascular disease, and I end up stopping it quite frequently because patients come in with new onset heart failure, or they've been on it and it's been continued. It is contraindicated according to the labeling. Now, diastolic dysfunction, as I told you, is the least common of the two heart failure types. And we manage it fairly similarly with regard to drug therapy as we do systolic dysfunction. One of the differences is that we typically use a lower dose of diuretic in these patients. They don't require as large of doses, and so we want to be really careful about reducing preload too much in this patient population. But again, the mortality benefit is just not been demonstrated in this particular patient population. So, for heart failure, things you need to make sure that you remember. If LV dysfunction is less than 40, you want an ACE inhibitor and beta blocker. ACE inhibitors are typically started first, beta blockers are then added. Titrate your beta blocker first and get it up to target doses. Consider spironolactone or an aldosterone antagonist for class 3 and 4 patients. If patients are optimized and still symptomatic, digoxin should be considered. If they're African American and optimized, hydralazine and isosorbide could be added to their heart failure regimen. So just those are some of the kind of key points to just keep in mind. All right, so AFib. Dr. Finks touched on this briefly. I'm going to go to it in a little bit more in depth. Again, this is a disease state that's managed both in and outpatient. Depending on hemodynamic status and how rapid their heart rate is, typically determines whether or not it's managed on the inpatient or outpatient setting. So we're going to start off with a case. 52-year-old male, several weeks of fluttering feeling in his chest on occasion over the past several weeks. Hypertension, he's receiving metoprolol for that, and all of his labs are within normal limits. So he comes into the clinic, an EKG is performed, we have a rhythm strip that basically shows an irregular rhythm, and so he's diagnosed with atrial fibrillation. His heart rate is 76 beats per minute, and his blood pressure is 130/78. So what would be the most appropriate to manage this patient's AFib? So that's what we're going to try to determine at this point going forward. Why do we care about AFib so much? AFib is a huge economic burden. It affects so many people, and no matter where you practice, you're going to encounter patients in AFib. As patients get older, the incidence increases, and we expect it to continue to grow as we continue to live longer. So it's a huge burden, and there are a lot of special situations with regard to managing AFib, certain patient populations that are managed a little bit differently than others. And then we also have the issue of anticoagulation in determining a patient's stroke risk as well as their bleeding risk. So that has a lot of balancing acts with regard to managing it as well. There are a lot of causes. You do not have to have underlying heart disease to have AFib. We can see young patients come in who have been binge drinking, who go into AFib. It's not that uncommon to see. You can see it in thyrotoxicosis. You can see it in patients postoperatively, and certain drugs, such as stimulants, can cause people to go into AFib. But there are also a lot of concomitant disease states that put people at risk for developing AFib as well. And those include chronic hypertension, valvular disease, sleep apnea. All of those are causes of AFib. Our goals of therapy, Dr. Finks touched on this, is to really rate control these folks. Ideally 60 to 80 at rest, 90 to 115 during exercise. Although there is some more recent data that a more lenient heart rate at rest is probably just as good as a more stringent heart rate goal for these patients. So we try to get them down to at least under 100 for the most part and try to rate control them fairly well. We do have to take into consideration concomitant diseases, and we also have to take into consideration of stroke risk. And that's one of the biggest issues with AFib that we always worry about is a patient's risk of stroke. Anticoagulation can consist of aspirin or the newer oral anticoagulants as well as warfarin. For rate control, we like to and prefer beta blockers, beta-1 selective agents. If a patient also has hypertension, you could go for a 2-for-1 special and use one of those that has alpha blockade. However, you typically do not get as good beta blockade with those agents as you do with, say, something like metoprolol. Metoprolol is probably our preferred agent for managing rate control. They're particularly helpful in patients who are active at controlling heart rate on exercise, so that's why we prefer these agents. Now, they're not the only ones that can be used. We can use calcium channel blockers as well, such as diltiazem and verapamil. However, in patients with systolic dysfunction, these particular agents should be avoided. But if patients have severe COPD or asthma, and when I say severe, wheezing at baseline, then perhaps a calcium channel blocker might be an option for them, or if they've experienced very undesirable side effects from beta blocker therapy. And one of those that we worry about most with heart failure patients, in addition to anyone else who's on a beta blocker, is fatigue. It's one of the most commonly reported and one of the ones that we have to do a lot of counseling about just so that we can keep patients on the drugs. Digoxin is an option. It should never be used as monotherapy. It will not be effective as a single agent. It is typically added on to a beta blocker or calcium channel blocker if you are unable to get adequate rate control on one of those single agents. Keep in mind that digoxin will not help with rate control on patients who are exercising. So once they're up, moving around and moving about, digoxin typically is ineffective. So it's really going to help control your resting heart rate more so than anything else. Now we have to worry about anticoagulation. So once we have the patient in AFib that we've identified, we then have to take the next step and determine whether or not this patient needs to be on anticoagulant therapy. And we do that by assessing their risk using something called the CHADS-2 score. So the CHADS-2 score gives point systems based on comorbid conditions, age, etc., and then determines their annualized risk of stroke. Based on that number, patients can be placed in a low, intermediate, or high risk category for stroke. So if you have a patient who has heart failure, that gets you 1 point, then hypertension, age, etc. So those are some of the things to keep in mind. Now, I think our patient was 52, had hypertension, so he has a risk factor of 1 at this point if we were to do a CHADS-2 on him. So we have to kind of now determine whether or not we need to anticoagulate him, and that's really going to be based on what the guidelines instruct us to do. And unfortunately, the guidelines are not necessarily consistent, and that's one of the issues. We have a whole lot of sets of guidelines put out by different organizations that kind of decide, a lot of it based on data and expert opinion, that then put together a consensus document with the individuals that are on the writing panel and say this is what we need to do. Now, for the Heart Rhythm Society, American College of Cardiology Foundation, AHA guidelines say a CHAD score of 1, warfarin, anticoagulant, or aspirin at a dose of 81 to 325 milligrams. That's consistent also with the AHA, American Stroke Association, non-valvular AFib guidelines. However, CHEST guidelines is a little bit more aggressive, and they say dabigatran over warfarin. Now, the reason dabigatran is listed here over some of the newer anticoagulants that have come out is that the guidelines were published and printed before these agents were approved. So you could substitute dabigatran for apixaban or rivaroxaban. Either of those would be fine. So something to keep in mind that the guidelines are not consistent except for when you get to a CHADS-2 score of 2. And with that in mind, you can basically choose any of the agents based on patient preference, cost, renal function, drug interactions, all those types of things we always take into account. Aspirin plus Plavix is a consideration in patients who are unable to take oral anticoagulants. So if we look at this patient, 52-year-old male with hypertension, what do we think is the best option for him to manage his AFib going forward? Right, D. So we'd put him on an anticoagulant. Now, one of the things to consider, now this is what the question proposed. I don't know that I would advocate necessarily anticoagulating this 52-year-old man and committing him to long-term anticoagulation, but it's a choice. And again, it really depends on what you think his overall risk is, and his bleeding risk has to be assessed as well, and which guidelines you put most value in. So again, they're not consistent. Hopefully for the exam, it'll be a little bit more cut and dry than that. So dabigatran is a direct thrombin inhibitor that was studied in a trial called the RELY trial. 150 milligrams twice a day was superior to warfarin for preventing thromboembolic stroke in patients with non-valvular AFib. Important note is that all the new anticoagulants do have to be adjusted for renal impairment. So keep in mind that if you have a patient that has fairly significant renal impairment, that warfarin is still an option. I don't know that warfarin is going to completely go away anytime soon. I think it's still something that we draw on. Additionally, cost comes into play a lot with these new agents. Patients are discharged on these agents, go home, try to get it filled, and realize that their copay is about $200. So that needs to be teased out as well in making a choice on which agent to initiate. Obviously, there's advantages. You can start the drug immediately, and patients are going to be at therapeutic effect within a relatively short period of time, so they don't have to necessarily be monitored really quickly with the warfarin and come back every few days and get an INR check. They don't have to be monitored going forward. So there are certainly a lot of advantages of these newer agents, but there's certainly not a one-size-fits-all. I've included this really more for completeness sake. I'm not going to spend an inordinate amount of time on this, of how to convert a patient from various anticoagulants. So I would spend a little bit more time on this if I were you. Dabigatran probably has a higher probability of being tested on than the newer agents, such as apixaban and rivaroxaban, simply by virtue of the fact that these drugs have been approved after dabigatran came out, and the guidelines haven't necessarily incorporated them. So if you're going to pick one to really emphasize more time on, I would choose dabigatran over the others. It does have some interesting drug interactions. One of the ones that we encounter commonly is dronedarone, in which you should reduce your dose by 50%. So keep that in mind. And then also, if they have renal impairment, less than 30, avoid use if you're on dronedarone. Rivaroxaban is a factor Xa inhibitor. It's another new agent that can be utilized, again, in non-valvular AFib. So if you get a test question, again, Dr. Finks has already talked about how to read the questions carefully. If patients have valvular AFib, none of these agents are approved. Warfarin is your go-to agent in that case. Again, if their kidneys don't work very well, you're going to have to either reduce your dose or avoid use. Again, I've included a lot of the drug interactions just so you have them. Those are in your book. And in the essence of time, I won't spend a lot of time on these. Apixaban is the newest. It's a twice-a-day drug. And again, if they have poor renal function, you can't use it. So creatinine clearance is less than 50. Now, what's kind of interesting with apixaban compared to the other two anticoagulants, the newer agents, is that it does incorporate age. So as we age, obviously bleeding risk increases, and this is one of the agents that have actually incorporated that into its package labeling. If they are 80 years of age or older and less than 60 kilograms or have a serum creatinine greater than 1.5, then you dose adjust. And again, conversion strategies are listed here for you and when to convert with these agents. And again, none of these agents are reversible. There are some reversible agents in phase 2 for the Xa inhibitors, and also monitoring these agents in the setting of some sort of a bleed or surgical procedure going forward, it's very, very difficult. Some of the coag parameters will correlate better than others, but it all depends on your assays. So a lot of things have to be taken into consideration of whether you can even utilize them. So here's our case. 67-year-old male with hypertension. He has moderate mitral valve insufficiency. He has had AFib for 4 years. His medications include ramipril, sotalol, digoxin, and warfarin. So the question here is that now this patient presents with increase in shortness of breath, palpitations, and bilateral lower extremity edema. He has an echocardiogram performed which now shows an ejection fraction of 35 to 40% and moderate valvular insufficiency. So the question proposed at this juncture is going to be, what is the most appropriate thing to do to manage this patient from an AFib standpoint? So let's talk a little bit more about how to manage this patient. Obviously, rate control versus rhythm control is always something that comes up. If we can rate control patients, that's our preferred method. Trying to keep patients in normal sinus rhythm creates a lot of issues with hospitalization and costs. It may be necessary to put people in normal sinus. There are certain situations, and we'll talk about those in a moment. But for the most part, if we can get patients rate controlled, we're okay with that. And again, we want to get them between that 60 to 80 or 80 to 100 type range at rest. So rate control is preferred, but again, in certain situations, you may not be able to do the rate control, and you may be kind of pushed to try to get the patient back into normal sinus rhythm. Keep in mind, it may not always be successful. We talk about trying to get patients into normal sinus. We talk about pharmacologic and electrical cardioversion, but we're not always successful. And patients can be cardioverted in the outpatient setting, does not require hospitalization. If you want to try to get them into normal sinus, you can consider antiarrhythmic therapy, or you can consider electrical cardioversion, but oftentimes the two go hand in hand. We'll usually use an antiarrhythmic first. We may start that and then try to cardiovert them to help facilitate the maintenance of normal sinus rhythm. So there's a lot of different strategies you may see out there. But as Dr. Finks has already mentioned, the concern is stroke risk. So if you were to try to cardiovert a patient in AFib, you have a stroke rate of 91% if they already have a thrombus. So that's huge. So these patients would then have to have a transesophageal echo and determine whether or not they have a clot. And then if they did, then you would not be able to cardiovert them. You would have to hold off on anticoagulation for a period of time. Now, again, as already mentioned in Dr. Finks' presentation, is the longer they're in it, there's a higher clot burden. So if you're less than 48 hours into this, you have a low risk of clot formation. You can probably be cardioverted just fine. However, the unfortunate part is not all patients know when they go into AFib. So unless they can definitively determine exactly at what point they went into this, it becomes very challenging, and you're better off doing a transesophageal echo to assess for clot formation prior to any type of antiarrhythmic therapy initiation or cardioversion. In patients with heart failure, this becomes a huge burden because the AFib causes a further reduction in cardiac output. They rely on what we call that atrial kick, which contributes 15 to 20% to their cardiac output. So for a heart failure patient, what can happen? Patient goes into a rapid rate, it exacerbates their heart failure. Or they can get volume up and go into AFib. So it's which one caused which one. So it creates a bit of a challenge. So in any case, if they're volume overloaded, you want to optimize their heart failure management first, get them volume down, and then consider whether or not they can be cardioverted or given a pharmacologic medication to go back to normal sinus rhythm. Dofetilide and amiodarone are your safest agents in the heart failure population. So if you think about our case, you might already have a good idea of maybe where we want to go with our patient. Again, rate control is beta blockers and DIG, and you want to avoid the calcium channel blockers. So amiodarone is probably the most efficacious at keeping patients in normal sinus rhythm. It it's a class 3 antiarrhythmic, but has properties of all 4 classes. It does have fairly decent beta blockade, so if patients are also on beta blockers, keep in mind that they can become overly bradycardic, so that's something to keep in the back of your mind. You may have to cut your beta blocker dose. Patients are loaded with amiodarone. The reason we load patients is because if we didn't, it would take 5.5 months to get to steady state, secondary to the drug's long half-life. This load here is simply an example. There is no definitive standard loading procedure. So I don't want you to spend time thinking about what the appropriate dose is for loading. You will see an abundance of strategies used to load patients. Some of it may be based on tolerability, body size. We sometimes use lower loading doses in frail elderly people. But for the most part, we try to get folks up to about 10 grams total of amiodarone. And even though amiodarone is only about 50% bioavailable orally, we generally don't take that into consideration. We take the total dose, gets to 10 grams, and go from there. It is hepatically metabolized. It has a lot of drug interactions, and I think the ones that are most important for you to know are digoxin and warfarin. We'll talk a little bit more about some of the statin dose limitations when we get into the dyslipidemia section, but there are new restrictions on the doses for simvastatin and lovastatin as well when given in combination with amiodarone. And then obviously the beta blockade, which I've already mentioned. Before a patient is initiated on amiodarone, there's a lot of tests that are recommended to be obtained. Amiodarone has a lot of long-term toxicities. So one of the things to always consider when initiating amiodarone is the patient's age and perhaps their life expectancy given their comorbid conditions. The longer the patients are on it, the higher the probability that a patient's going to develop some sort of adverse effect as a result. Some of them are not as severe, but some of them are potentially fatal, although not as common as some of the others. So baseline liver function tests are recommended. Baseline thyroid function test, amiodarone can cause hyper and hypothyroidism. Hypo is generally more common. Chest radiography, pulmonary fibrosis is one of the most serious side effects we worry about, but overall relatively low incidence. However, if patients already have significant underlying lung disease, that needs to be taken into consideration before drug initiation. Amiodarone can also cause corneal microdeposits, so a slit eye exam is also recommended. Those generally do not impair vision, but they tend to go away if the drug is discontinued, but just so that they can be monitored. And then skin toxicities, you could get what we call the Smurf syndrome or a bluish tint to your skin. It's very real and can be very pronounced. Photosensitivity, so patients need to wear sunscreen when they're on amiodarone as well. Sotalol is another agent that can be used for management or rate control of AFib and also to help maintain normal sinus rhythm. Its efficacy is significantly lower than amiodarone. And again, as Dr. Finks mentioned, this particular drug requires adjustment for renal impairment. Amiodarone does not. That's one of the advantages of that particular agent over many of the antiarrhythmics in general. The problem is it does need to be initiated in the hospital depending on which arrhythmia you use it for. Some physicians are comfortable with starting it as an outpatient. Not all are. It all depends on really how comfortable the physician is with the drug itself. And again, contraindicated with a creatinine clearance less than 40. And then we have dofetilide. The other thing with sotalol, it said contraindicated in heart failure. If patients really do not have controlled heart failure or symptomatic, then sotalol is probably not the best choice to use, and I would avoid it. So for dofetilide, the efficacy is about the same as sotalol. We use it quite a bit, but again, patients have to go in the hospital and receive at least 5 doses, so it's typically a 3-day stay. Also, the disadvantage is if a patient misses multiple doses, the recommendation is that they come back into the hospital for reinitiation of therapy. That has created a lot of contention with cardiologists because they don't feel that the patients need to come back in. But if you read the package labeling and part of the REMS program in which this drug falls under, that is what's recommended. It is also renally eliminated. So again, heart failure patients can have tenuous renal function. So you need to be cautious and the dose needs to be adjusted as well. Drug interactions with dofetilide I would recommend you be familiar with. There are several in which are contraindicated with dofetilide. One of the more common ones that's seen in clinical practice is HCTZ. Most probably wouldn't even think that it interacts with dofetilide, but it increases dofetilide concentrations by about 40%. So it is contraindicated. So if you try to look at AFib and management and how can I simplify this, all these antiarrhythmics and which drug to use when, amiodarone pretty much is wide open. Doesn't require renal adjustment. You can use it in almost any disease state. Again, so it's probably your most widely utilized antiarrhythmic therapy, and it's the most efficacious compared to the others for the most part. So if patients don't have heart disease and they don't have any kind of heart dysfunction, the door is much more wide open than if they have comorbid conditions such as heart failure. So think about if they have coronary disease, if they have heart failure, dofetilide and amiodarone are your best for patients with heart failure. Okay? Those are probably going to be your best. If they have coronary disease and you want a beta blocker, you could use sotalol. That might be an option for you as well. Dronedarone should be avoided in heart failure completely. It's contraindicated in patients who have had a recent hospitalization for heart failure and in class 4 heart failure. I guess supposedly you could use it if they were class 2, but again, the efficacy of the drug is not that vast, so would probably not utilize it that often. And I've seen its use in clinical practice deteriorate quite a bit. In terms of AFib, if you wanted to cardiovert a patient, I would be familiar with this table. Again, we talked about that 48-hour window of when a clot can form. If they're under 48 hours, again, there's some disparity in the guidelines into whether or not you should anticoagulate before or after. Some will say anticoagulate after, some say it's not necessary, or to take into a patient's stroke risk and determine whether or not you want to anticoagulate. If they have been in it for greater than 48 hours, if you want to cardiovert them, you would have to do a transesophageal echo. Or you could just hold off and anticoagulate them for a few weeks before and then anticoagulate them after. And the reason why they have to be anticoagulated after the cardioversion, you might ask, well, we've put them into normal sinus rhythm. Why do we need to anticoagulate these patients? When they're cardioverted, either with drugs or with electricity, the atria are stunned. And the walls of the atria are not contracting normally. And that takes about 3 weeks or so for full function of the atria to start kicking in. So there's still risk for clot. In fact, they're at very high risk for clot formation post-cardioversion. So in our case, in this patient who has ramipril, sotalol, digoxin, and warfarin, who has new heart failure diagnosed with an ejection fraction of 35 to 40%, the question is, how are we going to manage this patient now with regard to his AFib? He's had AFib for 4 years, so one could say, well, why do we need to make a change? Well, what's the big thing that changed for this patient? And that is now he has new onset heart failure. So then the question remains is, what change do you want to make to his antiarrhythmic regimen? What do you think would be the safest? Yeah, so probably amiodarone to try to keep him in normal sinus rhythm would probably be your best choice there. Okay, so hypertension. So this is a 50-year-old African-American male who is hospital discharged with an acute myocardial infarction. He has hypertension, is on HCTZ. He has an EF that's preserved, so it's greater than 60% or normal. Blood pressure is 150/94. So what we're going to do is try to manage his hypertension and determine which strategy is best. So here are your choices that we're going to select from momentarily once we go through the information. So first we have to define hypertension. Is our patient hypertensive? Well, by definition, yes. So hypertension is defined by a blood pressure of greater than or equal to 140/90. And then we have our stages of hypertension as well. If patients are normal, it's less than 120. That's what's considered normal, although again that may change with the incoming guidelines. We don't know yet. Pre-hypertension is between 120 and 139. Stage 1 is between 140 and 159, which is about where our patient sits with a systolic of 150. And then the stage 2 is greater than 160. And the difference between stage 1 and stage 2 is that stage 1, granted it's a little bit of a lower blood pressure, but you might be able to get away with just monotherapy for management, whereas in patients with stage 2 hypertension, it's unlikely that a single agent is going to control them adequately, and you're probably going to have to initiate with a 2-drug regimen from the beginning. So that's always something to kind of keep in mind when you see this out in the community in clinical practice. If a patient comes in with a high pressure of like 165, then you're probably going to need to start 2 medications. But first and foremost, as with everything we talk about today, is lifestyle modifications. It's the hardest thing to implement, but it's so critical. It can have such an impact on the natural progression of many cardiovascular diseases, but it is difficult for patients to adopt. Exercise lowers blood pressure, reducing sodium intake, all of those things. I can tell you, however, 2 grams of salt a day or sodium a day is extremely difficult, if not impossible to do. So it's a little bit too restrictive, and it has to be a little bit more lenient to some degree. So weight reduction, physical activity, all these things should be incorporated in addition to drug therapy. So our goals at JNC7, again, this is an old guideline, but for the purposes of the exam, this is what you really need to focus on. Goal is less than 140/90 for all conditions with the exception of patients with diabetes or CKD or albuminuria, where the goal is less than 130/80. If they have systolic heart failure, the goal is 120/80. Most of the time, patients with fairly advanced heart failure will have lower pressures than this. If they can mount those types of pressures, that's actually a good thing for us, because that means we can titrate their meds. So that works out to our advantage if that happens, but it's not that common. There are other antihypertensive guidelines out there. I would not spend a lot of time focusing on them because they are controversial, there's no consensus, and I would just focus on the JNC7. So how do we do this in a stepwise fashion? Well, some of this I've already discussed, and if you have stage 1 hypertension, you can start with an ACE inhibitor, thiazide diuretic, or if that's not going to be adequate, or you think they won't respond, or maybe they're already on HCTZ, you don't think that just using that is going to be beneficial, then of course adding a second agent. Stage 2, again, you're probably going to have to do 2 agents. ACE inhibitors, diuretic combination, and there are some ACE diuretic combinations on the $4 list too, so you can do a relatively inexpensive combination if needed. So the compelling indications. Again, this can be a little bit overwhelming, but we're kind of going to try to break it down and make it a little bit easier for you. So if patients have coronary disease, so they've had a recent MI, they have coronary disease, beta blockers are your preferred first-line agent. Beta blockers are not the best antihypertensives. Hopefully these patients are already on beta blockers if they have coronary disease or have had a recent MI. But if they have LV dysfunction, chronic kidney disease, or diabetes, ACE inhibitors are the way to go. So you can kind of simplify it a little bit so it's not quite so many different disease states trying to memorize and remember which agent goes where. So ACE inhibitors, you really can't go wrong. Beta blockers are going to be preferred with the coronary vascular disease patients. And then diuretics can always be added as well. So going back to our case here, we have this gentleman who's status post-MI, and he's already on HCTZ. So the question is he hypertensive? By definition, does he have hypertension? Yes. Okay, his blood pressure is 150/94. The definition is greater than 140/90. And he takes an antihypertensive medication already. So then, should we recommend lifestyle changes for this gentleman? Absolutely. Absolutely. He has hypertension, right? So we're going to do that. And then our blood pressure goal should be what? He's not diabetic, right? He doesn't have LV dysfunction. So our goal is going to be less than 140/90. Okay, that's going to be our goal. So does he have any compelling indications? Yes, he's had a recent myocardial infarction. So he does have a compelling indication. So if you look at that chart, that second page of the chart under compelling indications, you know exactly which medication is probably preferred. So beta blockers are your first line therapy, and then you could add an ACE or an ARB if needed. So to answer our question then, what's the most appropriate approach to manage this patient's hypertension? So which one do you think is the most appropriate? Yeah. So adding a beta blocker would be the most appropriate thing to do for this individual to get his blood pressure down. Okay. So now we have a 47-year-old female who has type 2 diabetes and microalbuminuria. She has a blood pressure of 138/88, and her previous was 136/85. Her labs are listed there for you, notable for a serum creatinine of 1.8, so she has a little bit of renal insufficiency. She's currently on glyburide. So the question is, what are we going to do with regard to her therapeutic regimen? Well, is she hypertensive? No, right? She doesn't meet the definition. Her blood pressure is below 140/90. Should we recommend lifestyle modifications? Absolutely. So she has pre-hypertension. Of course, she's also diabetic. So her blood pressure goal is going to be less than 130/80. For the diabetes as well as the renal disease, that's her goal. And any compelling indications? Yes, she has diabetes and kidney disease. So our first line therapy for her is an ACE or an ARB. So that's the choice. So if we had to make a decision based on this, which one of these answers do you think is the most appropriate? Correct. So an ACE inhibitor. We're going to initiate an ACE inhibitor. And you don't have to be super aggressive. I mean, she's not really hypertensive. She's pre-hypertensive, but she's diabetic. So you probably want to get her on an ACE inhibitor for that. Okay, so hypertension, just to summarize that again, looking at how high the blood pressure is, looking at their compelling indications, determining whether or not you can start with a 1-drug regimen versus a 2-drug regimen, depending on what they're already on. And again, avoiding salt, avoiding medications that can increase blood pressure, such as chronic use of nonsteroidals, steroids, all the things we talked about with heart failure that increase fluid retention, kind of some of them are the same way. You can increase your blood pressure with nonsteroidals as well. And make hypertension worse, and a lot of sodium restriction, although again that 2 grams is very restrictive. All right, so we're going to finish this off and talk about dyslipidemia and get you out of here. All right, so this is a 63-year-old woman who's just finished 6 months of diet and exercise for her dyslipidemia. She has a history of gout, CHF, hypertension, and asthma, and a 15-pack-year history of tobacco, but she quit 3 years ago. She drinks 3 beers a day. We have no medical records. She's adopted, so we have no way of knowing what her family history is. She does have a cholesterol panel, and she has a blood pressure of 134/84. Her cholesterol panel is an LDL 193, total cholesterol of 236, triglycerides 148. So what we're going to attempt to answer here is identifying how many risk factors she has, and then ultimately determining what her LDL goal should be, and then try to decide what would be the most appropriate therapy for her to be initiated on. But before we do, just to kind of break down the lipid and lipoprotein classes by NCEP guidelines, optimally with patients at risk, depending on risk factors, the LDL is going to be your primary target. There's one exception to that, which I'll talk about momentarily, but LDL is what we always typically go after first. And then once you get your LDL to goal, if that is your primary target, then you want to also kind of look at all your other lipid parameters and try to get them to your goal as well. So you want triglycerides less than 150, total cholesterol less than 200, and an HDL greater than 60, which is not easy to do. It's something that's very difficult. So first we have to assess our patient's risk. So we have to determine how many risk factors she has, and then do a Framingham risk assessment score to kind of help us out, determining what her LDL goal should be. So for patients with multiple 2 or more risk factors, you perform a Framingham risk assessment. If they have 0 to 1 risk factor, it's really not necessary because they're at low risk. If they already have coronary disease, there's no reason to perform it either. So keep that in mind. The Framingham risk calculator is available online. You can plug in the numbers and it gives you a percentage. And typically you're looking for patients with like between 10 and 20% on their Framingham risk score to help further categorize them to determine their ultimate LDL goal. So it's based on gender, age, total cholesterol, smoking, high density lipoprotein, and systolic blood pressure. So if we calculated our patient's Framingham risk score, it would be between roughly around 5%. So not really high. That's something to keep in mind. And then we have to identify her risk factors. So her risk factors, cigarette smoking. Is cigarette smoking a risk factor for her? Well, she quit. So cigarette smoking is actually not a risk factor if they've quit. So that's kind of something to know. It's a little bit of a trick question, but it does not count as a risk factor if they have stopped smoking. It's for active smoking. Hypertension, family history, coronary disease in first degree male or female in your family, and age. So she was hypertensive, and her age, she's 65, I believe. So those are a couple of risk factors for her. And then if you have a high HDL, if you're blessed with a high HDL, that actually takes 1 point away from you. She unfortunately was not. So some of the things to also keep in mind is that there are certain situations in which patients are considered high risk, and if they have coronary disease, obviously that puts them at high risk, and there are also risk equivalents. So diabetes is a risk equivalent. If patients don't have known coronary disease but have peripheral arterial disease, carotid disease, you don't just have isolated carotid disease. Typically you're going to have disease elsewhere. So those patients are considered high-risk patients as well. Their 10-year risk is going to be more than 20% based on Framingham. So if we look at our goals, and then we'll try to figure out what it is for our patient, high risk with CAD or CAD risk equivalents with a 10-year risk score of greater than 20%, the goal is less than 100, with an optional goal of less than 70. In clinical practice, I can tell you that we generally push it as low as we can. As Dr. Fink's already mentioned, with patients with acute coronary syndromes, we do intense, high-intensity statin therapy in those patients. 80 milligrams of atorvastatin is what's recommended by the guidelines, the new STEMI guidelines of 2013, because that's the most studied. It's the most well-studied, is that particular dose and drug. But we also have to be mindful of the fact, and we'll discuss this momentarily, is that not all patients can tolerate high-intensity statin therapy. And what's more important is that the patients take the medication for the benefits that they are derived from, rather than necessarily saying we have to get them on maximum doses. So optional less than 70, we push everyone to that. Even if their LDL, when we see them, if they have coronary disease and their LDL is already right around that, we're still going to be aggressive in treatment. Moderate high risk, 2+ risk factors, your goal is less than 130 with an optional goal of less than 100. And then if you have a 10-year risk of less than 10%, I think our patient has a 5% risk, and she has 2 risk factors, goal is less than 130. And then low risk is less than 160. So if you looked at her risk factors, how many does she have that are present? So she has 2. She has hypertension and age. Those are the 2 risk factors that she has. So according to the NCEP guidelines then, based on the fact that her Framingham risk is around 5%, what is her LDL goal? So if we look at moderate risk with 2+ risk factors and a 10-year risk of less than 10%, it's less than 130. So that's where we are. She's sitting at 193 right now. So we need to get her to 130 or below. That's going to be our goal for her. So we have to do that by incorporating, once again, lifestyle modifications, diet, exercise, and weight loss. And you can make some significant changes in LDL if you adapt lifestyle modifications. Again, very difficult to do for most patients, but certainly something to recommend and talk about at every single outpatient visit to reinforce. Determining which therapy to use. As I said previously, in most cases, the LDL is going to be your primary target. The exception to that is when patients have high triglyceride concentrations greater than 500. In that case, triglyceride lowering becomes your primary goal, and LDL then shifts to the side. And the reason being is that high triglyceride levels can lead to pancreatitis. And typically we may treat both the triglycerides and put them on LDL lowering simultaneously. But the important thing to realize, if you have a patient that has high triglycerides, it's important to ensure that it is a fasting lipid panel, between 9 and 12-hour fast, because triglycerides will be the most highly influenced if you've consumed a high-fat meal within the recent few hours prior to getting your labs drawn. So typically what I do is, if I cannot confirm and they can't remember the last time or what they ate or when they ate, which a lot of patients are poor historians, unfortunately, which makes our job a little bit harder, I'll just repeat the lipid panel and stress the fact that it does need to be a fasting level. So those are some of the things that that's the only time, it's the only exception to not targeting LDL first. And then we can then target our other lipid parameters, such as our HDL, total cholesterol, etc. Now, in the setting of high triglycerides, if they're above 400, the Friedewald equation becomes unreliable with regard to getting an adequate or accurate LDL. So there are certain labs, and our institution does this, we can get a direct LDL where they measure it, and that's always an option. But again, cost and insurance reimbursement and things of that nature are always something to take into consideration. But one thing you can do is take the non-HDL. So the non-HDL you can do irrespective of fasting state. It's a total minus HDL. And the goal for that is 30 above your LDL goal. So if you have a patient that comes in and you want to get a lipid panel and they haven't necessarily fasted, but you want to kind of get a sense of whether or not we should start treatment because you think they're fairly high risk. The patient's not going to be able to come back anytime soon, a lot of issues. You can get a lipid panel, calculate the non-HDL, and if that comes back higher than 30 above your LDL goal, you know you need to be aggressive. So you can kind of use that as your gauge if you don't have a fasting lipid panel. And the non-HDL tends to encompass a lot of the atherogenic particles, so that's one of the reasons why they're looking at this as a potential a target for how we monitor patients with lipid abnormalities and in the setting of hyperlipidemia. So it's always an advantage that you can utilize if you don't know for sure if it's a fasting lipid panel. Okay, so our patient case, the next thing that we're going to do is try to determine what's the most appropriate step. So we already mentioned her LDL is 193, her goal is 130. We want to get her down, so that's roughly about a 33% reduction that she's going to need in her LDL. So that's where we have to go. How do we get there? Statins are your staple. They are your primary LDL reducing agents. They are the most widely prescribed drugs, and they have the most data with regard to cardiovascular event reduction, mortality reduction, etc. So these drugs inhibit 3-hydroxy-3-methyl-coenzyme A, glutarol coenzyme A reductase. So they inhibit kind of the rate-limiting step of cholesterol biosynthesis, resulting in LDL reduction. They vary depending on their dose and potency, and we'll talk about that momentarily. Dose ranges on LDL reduction range from anywhere from 24 to 60% reduction in LDL. Some patients do have a more profound reduction. I've seen patients have even greater than 60% reductions in LDL. Now, it's hard to say if that's just the drug or if they've incorporated a lot of lifestyle modifications that could have impacted that as well, but I have seen greater than that in clinical practice. Triglyceride reduction is around 7 to 40%, and they raise HDL only modestly. So these are not an agent you want to put on board to try to get HDL up. If you're looking at an HDL level of 34 and you can get a 10% increase in HDL, that's not a very robust increase. So these drugs are not your option for that particular purpose, and we'll talk about what drug we do use in a little while. So when selecting an agent, you want to consider how much reduction you need, and the calculation is here for you. We mentioned our patient needs about a 33% reduction, so we want to pick an agent that's going to lower her LDL to get her below 130, get her to goal. And so we have to determine which drug and which dose is most appropriate. So outcomes data, statins have a lot of data with them, and there's a lot of pleiotropic effects, plaque stabilization, vascular endothelium effects, that these drugs are highly touted in the literature as well as in clinical practice that almost everyone should be on one. So patients, it's imperative that they take it. And these drugs are not devoid of side effects, which we'll also discuss. So it's imperative that we not just say high-intensity statin therapy for a post-MI patient. We also have to look at a lot of other things such as tolerability. Cost also plays into it, but we want these patients to take them. Statistically, 50% of patients stop taking statin therapy within 6 months of initiation. It's a significant number of patients that stop taking it. Could be due to side effects, mostly it is. Could be due to cost, it could be just patient non-compliance in general. A lot of people are on these medications, so as we talk to friends and family, if they've had a problem with these drugs, then perhaps, oh, maybe that's the reason I'm having this problem too, because it's the drug, maybe I shouldn't take it. And you read about things on the internet, and that also can sometimes impact patients' ability or willingness to take medications in general. So we have a lot of things acting against us to some degree, but it's imperative that we stress the importance and the benefits that these drugs actually provide to the natural history of this disease. So the side effects that are most common, myalgia. Probably over a third of patients will complain of some sort of muscle aches or weakness with statin therapy. There's a lot of things to factor into play. There are a number of risk factors for statin-associated muscle aches and weakness, so we have to rule those out. We have to rule out drug interactions. We have to look at the dose they're on, and when did these symptoms start in relation to when the drug was initiated. So myalgias typically are not associated with any kind of muscle breakdown or CK elevation. Myopathy is a little bit more concerning. This is where they have complaints and you do have an elevation in your CK greater than 10 times the upper limit of normal. So I think if patients come in and complain of muscle aches and weakness, I think you're probably obligated to get a CK just to rule it out to ensure that there isn't anything serious going on. And then the one that we can get most concerned about is rhabdomyolysis. This is relatively rare. The most common time I've ever seen this is in the combination of drug interactions. That's when I've seen it most commonly. And I think I've only seen 3 cases in 20 years. It's relatively rare, even though we worry a lot about it. So some of the risk factors to take into consideration: increasing age, being female, renal insufficiency. Believe it or not, some of the statins do require dose adjustment in renal insufficiency. Hepatic dysfunction, hypothyroidism. So that's something that we will typically do if a patient complains of muscle aches or weakness, because hypothyroidism also causes a lot of fatigue and other symptoms. We'll get a thyroid panel, especially if it's an older female, because the prevalence increases with age, especially in women, and you can quickly rule that out as a cause. Diet, grapefruit juice, drug interaction there, drug-food interaction. Typically it takes more than a quart a day in order to really have a profound effect. So if you have a patient that really loves grapefruit, they'd have to love it a lot. So typically I let patients have a grapefruit for breakfast, and I generally don't have a problem with that. And then obviously alcohol abuse, polypharmacy, etc. Some of the properties of statins may play into it. Some of them are more theoretical than clinically documented. The lipophilicity, whether or not it's lipophilic versus hydrophilic. Some may argue that those that are hydrophilic have less tissue distribution and may have a less propensity to cause muscle aches. Again, if you have a patient that's on a lipophilic agent and they develop muscle aches, could you switch them just to see? Absolutely, there's no harm in doing so. And then bioavailability may play into a role, and obviously the drug interaction piece. Which leads me to drug interactions in general. I would familiarize yourself with the simvastatin labeling and lovastatin labeling. Those have recently been revised with a lot of new cut points with a lot of drugs in order to minimize the risk of muscle toxicity. So the lovastatin one, I believe, was earlier, late last year, early this year, and simvastatin has been recent. I think it was in 2011, was recently updated. So I would definitely make sure that you review those. And I only put a brief number of them. You have a whole table in your handout, so familiarize yourself with that. I apologize for the abbreviations of LOVA, SIMVA, but there was no way for me to get it all on this slide just to be able to discuss it with you. Out of all of these drug interactions, the one that I've seen in clinical practice that has a higher propensity to cause rhabdomyolysis is when statins are combined with gemfibrozil. And if you look at this table, you can see that with regard to fibrate therapy, gemfibrozil is the biggest offender. It impacts almost every statin, with the exception of fluvastatin, and increases statin levels significantly. The gemfibrozil inhibits glucuronidation, which is a metabolic pathway for statins, raising the statin levels, therefore increasing the risk of statin-associated adverse effects. So if you have to combine a fibrate, and we'll talk about fibrate's role in the management of dyslipidemia, gemfibrozil is probably not the best option when using statins in combination with fibrate. Some other updates on warnings. It used to be that it was recommended to get LFTs before and after every dose titration of statins. That is way since gone now. It's taken several years to get to this point. The National Lipid Association Statin Safety Task Force actually put together a recommendation several years ago to do away with the LFT monitoring with regard to statins because it was not a reliable indicator of hepatotoxicity. It was increasing costs and completely unnecessary to do so. It's taken the FDA a little while to follow suit, but they finally came through, and so now we have a little bit of leniency with the LFT monitoring. Baseline is reasonable. There's no routine monitoring required with dose titration, et cetera. Let patients know if they experience right upper quadrant pain, notice yellowing of the skin. Those types of symptoms may be justified in getting a repeat liver panel. However, the overall incidence or risk of statin-induced fulminant hepatic failure is 1 in a million. It's extremely rare. It is about as rare as you developing idiopathic hepatotoxicity, which is also 1 in a million. So I think we put a lot of concern into something unnecessarily, and so we finally have some relief with what the recommendations are showing us to do. With regard to memory loss and confusion, there's more and more data coming out. There is some data that says that it certainly can. It generally is not serious. You can certainly stop the drug and see if that does have an impact on the memory and see if it resolves. It could be just the natural progression of the patient's underlying memory in and of itself, so it's kind of hard to necessarily tease that out. Another warning that's been hit on the labeling is the risk of diabetes and increase in blood glucose levels. I think this has probably been way overstated. It's probably not that significant. I know we still don't think, or we're really not sure if it's really the drug itself that's causing this, and so I think there's just a lot more information that's needed out there. Obviously, getting diabetic patients under control is imperative in order to minimize long-term consequences of the disease state, but statin therapy also has a lot of benefit, and I think it's really important that you weigh the benefit versus the risk, and the risk of increase in blood glucose levels, based on what I've read, is certainly no reason not to initiate statin therapy. So in terms of lowering, it is drug and dose specific. The most potent agents are going to be atorvastatin and rosuvastatin, where you can get up to a 60% reduction in LDL. And then your weaker agent would be fluvastatin, and then you have all your others that are kind of middle of the road. But again, we also have to take into account cost, side effects, drug interactions when selecting an agent. Even though we want that intense therapy, it may not always be possible to do so. From a pharmacokinetic standpoint, you hear a lot about taking statins at night. Cholesterol is synthesized at its highest rate in the evening hours, so those that have a shorter half-life will only impact the H&G-CoA reductase for a shorter period of time. So there's thought that perhaps the benefit is higher, is better if you do it at night when you synthesize cholesterol at its highest rate. My philosophy on that is there have been some really small studies looking at morning versus evening time administration of these shorter duration statins. It's not a huge difference in LDL, and from a perspective of patient compliance, if it's easier for the patient to remember to take it in the morning, that's what would be recommended. But just bear in mind that some of these package labelings do recommend taking it in the evening, so for the purposes of the exam, I would go by what the labeling states, but from a clinical and realistic standpoint, it's not always the way we do it in clinical practice. And then the other piece of that is the longer half-life agents such as Lipitor and Crestor, or rosuvastatin and atorvastatin. Those agents can be dosed at any time of day because they do have longer half-lives. So renal impairment. As I mentioned, some of the statins do require dose adjustments for renal insufficiency. So if patients are on hemodialysis, there's really not a lot of data with using Crestor in these patients with kind of end-stage sort of renal insufficiency. So I'd be very cautious. The one that typically is the go-to agent in this particular case is atorvastatin. It appears to be the safest, has the most data in this patient population. It's probably the one to draw to from that standpoint. So just keep in mind some of the limitations with regard to renal impairment that may come into play when you need to initiate therapy. Simvastatin 80 at that dose is no longer advocated to even be utilized in clinical practice unless the patient has been on it and stabilized. We would never titrate people up to that 80 milligram dose any longer. So the bile acid sequestrants are another agent, and in terms of focus and where you need to concentrate your time with the lipid-lowering therapies, statins are where you need to focus your time, okay? The bile acid sequestrants and a lot of the other agents I'm going to briefly run through do not have the robust amount of data. They do have their utility in clinical practice in certain situations, but I wouldn't spend a lot of time memorizing and knowing a lot about them. I would know their place in therapy, but I wouldn't go too extensive into the details. So bile acid sequestrants are certainly an alternative. They can lower LDL by up to 26%. They may increase triglycerides a little bit. The nice thing about bile acid sequestrants is they're not absorbed. So if you had a pregnant patient, for example, had familial hypercholesterolemia, that might be an option. But as a general rule, we just defer therapy in those patients anyway. They also are not very palatable. They're not very well tolerated. A lot of GI side effects, cramping, abdominal pain. So not necessarily the first line that I would want to go to if a patient couldn't tolerate a statin, because it's highly unlikely they would tolerate this. Niacin. This is our go-to for raising HDL predominantly. Raises HDL by up to 26%. Niacin's come under a lot of scrutiny lately. I'm not going to go into the details of all the data, so I'm not really sure how the new guidelines are going to put all this into perspective and its use. But what is important is you can use the prescription strength, and you can also use the over-the-counter regular release niacin to manage these patients. The prescription strength, the niaspan, is a little bit pricey, so an over-the-counter regular release might be a better option. The slow-release niacin is not really all that well-liked because it does have a higher incidence of hepatotoxicity, so if you can avoid that one, probably recommend it. The prescription niaspan does not have as much hepatotoxicity, and it doesn't have as much flushing as you have with the over-the-counter. The one thing I will caution you on with niacin is the flushing. This can occur with the niaspan, it can occur with any product. It's more prevalent with the immediate release agents. And there's a couple of ways to combat it. Recommendation of an aspirin, 325, 30 minutes prior to the niacin administration. 81 milligrams of dose of aspirin is not sufficient to block prostaglandin D2 that is responsible for the flushing. So it would have to be a full dose aspirin. Niaspan, if you take it at night, if you did have some flushing, you'd likely sleep through it. Patients do become tolerant to it over time. That's why we increase the dose at a very slow rate in order to allow tolerance and minimize the risk of toxicity. Also, avoiding hot, spicy foods, hot showers, those types of things can also minimize the flushing. Fibrates are kind of our go-to for triglycerides. You can get over a 50% reduction in triglycerides. But again, if you also have patients on statin, which more than likely you will, fenofibrate is the way to go because you don't want to use gemfibrozil in combination with your statins. So keep that in mind. However, gemfibrozil is the $4 fenofibrate or fibrate, and all the other ones are more expensive, so you have to balance that. But we do have some other agents that I'll mention in just a second in terms of what we can use for triglycerides when that instance does occur. Ezetimibe is add-on to statin therapy for additional LDL reduction. I've seen patients put on as monotherapy when they can't tolerate statins. We do have patients that really just cannot tolerate them no matter what. The statins have been dosed, once a week, 3 times a week, just to get people on them because of the benefit. But sometimes you can't, and so Zetia, perhaps as monotherapy, may be the best option you have, and that's fine to do. However, keep in mind there's no good outcomes data for the use of a Zetia. And then the other one for lowering triglycerides are the fish oils. You can buy these over the counter as well. But we do have a couple of prescriptions, such as Lavazza, and we have a new one called Vasepa that was just recently approved. And these require up to 4 capsules a day. They are expensive. Even the over-the-counter fish oil is expensive. So that's something to keep in mind with regard to cost, but it is an alternative if patients can't afford a fenofibrate. You just have to balance which one's the most efficacious, but lifestyle modifications also work as well. And this is the Vasepa. This is the newer one. It's the EPA-only agent. It decreases triglycerides by about 33%. So that's one of the another option as well. I have not seen this prescribed yet in clinical practice since it's been approved, and it's 2 grams twice a day with food. So to summarize, Statins are your LDL lowering agent, up to 60% reduction with rosuvastatin and atorvastatin. For your HDL, niacin is the drug you want to go to. Keep in mind statins do increase HDL, but only by a marginal degree. Zetia is add-on or monotherapy if they can't tolerate anything else. Fibrates are your go-to for triglyceride lowering. Keep in mind if you use a statin, Zimfibrazil is not the one you want to use. And bile acid sequestrants, I guess if you want to use them for LDL reduction, you can, but again, most patients will not tolerate them. They've really fallen out of favor. So going back to our patient case, which one of the following medications is best to recommend to treat MM's lipids? So which one do you think? She needs a 33% reduction in LDL. Correct. Lipitor 20 will get her there. It has mortality benefit, it's a statin, it'll get her to goal, so that's the optimal choice of therapy for her. Okay, so I know that was fast. In summary, I thank you for your attention. So again, focus on those key points that I've mentioned for those 4 disease states. Refer to the chronic stable angina section in your chapter, and I'll stick around if you have questions prior to lunch, and I wish everyone a safe trip home. Thank you.